So
Yeah.
anyway, all right. So Karen Battistoni, is that
I
right?
am
Did I say
so
it right?
impressed.
Well, I'm
Yes, that
Italian,
you said
so
it right, and
yeah.
when you posted that you spelled it right. Like
But yeah.
I'm impressed.
Well, I mean, I can't take all the credit for that. ChatGPT did it. I did like look it up, but I'm Italian, so I understand the phonetics
Okay, yeah.
because my last name is famously hard to say. It's Gioni because the GHI becomes like it's Gi. So CHI is key, GHI is Gi because of the phonetics. But anyway, so where, besides sort of like doing our nightly skincare routine that we have to make sure that we keep up with, that I don't do, to be honest with you, I need to like get it going more. But where, who are you and what do you do?
So I am a CV and critical care educator in the Texas Medical Center.
Okay.
I've been a nurse for a little over 15 years, and so I was a nurse before I could drink. And for a long time, I loved the bedside. That was where my heart really was, and that's where all of my kind of knowledge and experience comes from.
Right.
And I think that's the edge that I bring into the education space is that I didn't learn it in a book. Of course we're doing the research, we're looking through those things, but
Mm-hmm.
I really started to identify the gap between what we're taught and
Yeah.
what we're expected to know and the
Yeah.
space we're expected to practice in. And
Yeah.
so that's where my education grew. And that's where I decided, you know what, I want to take kind of a broader audience and see where that goes. So that's where the Instagram was born. It's already
Nice.
like well far away from where I ever thought it could be. So
Yeah. I mean, likewise, honestly, I think that goes to highlight how maybe besides doctoring, because we have residency, like for nursing, and you probably remember because not, you know, because you've been doing it for 15 years, but there was a time where you had to sort of like be a nurse for a little before you went into the ICU, right? Like be like a floor nurse or med surge or something, and sort of like cut your teeth there, and then you can go into the ICU, which is almost like a badge of honor in some ways. Like, oh, like you're an ICU nurse. Now we sort of can't, have enough ICU nurses for whatever reason. So we're getting a lot of new grads, a lot of people that maybe not as much experience or sort of, moving in and out of different like specialized ICU. So the education piece has been lacking, which is it's sort of like hand in hand with the ventilator piece, like mechanical ventilation, because there's not like a lot of structured education out there. So for RTs, for physicians, a lot of people that contact me are nurses too that want to know like that didn't get a lot of training or don't know anything about it. How do they sort of like step their game up? Then you add in all this like MCS stuff, right? And it's like moving at the speed of light, ECMO, you know, VADs, right-sided VADs, Impellas, ECPellas, VAV ECMO. So plus on top of the other like surgical stuff like transplant, heart, lung, and all that kind of stuff. So yeah, so definitely a need. I reached out because I guess so. You mainly are talking with or talk with, train cardiac ICU nurses or CVICU nurses, like those, like that
yeah,
subset of nursing.
yeah, the unit that I work for now is a shared medical and CVICU, but my background is
Really? Shared
CV.
medical CVICU. That's like talk about complete polar ends of the spectrum. Holy
Oh,
Toledo.
for sure, for
Nice.
sure.
So they're
But I mean, you
so
still, that medical ICU, that's still really, really sick, really, really complex.
oh yeah.
And I think people get lost in the sauce with CV, thinking like, oh, this, I call it the sexy squiggles.
Yeah, yeah.
Like looking
Definitely
at
the
all
sexy.
the
I know.
hemodynamics.
There's
But
nothing there's nothing sexier than like we're going to put them on ECMO, right? It's like the thing to do,
it's
and
so sleek, so
it is
so
it's
ready.
yes, just some, massive Avalon catheter in the neck. There's nothing sleeker about it. It is the sexy thing for sure. And I'm, part of the reasons why I kind of switched jobs because I wanted to do more MCS because I really didn't do a lot in fellowship. I didn't want to do it. I mean, I was sort of like in the COVID haze burnout, so I was like, I don't, I can't
Mm.
do this anymore. But I got to tell you, after that, I mean, the only other place where you can sort of scratch that itch is the CVICU because no one crashes harder and faster than like, some post cardiac surgery patient or something, or some acute heart failure, or like some blown valve or RV dysfunction, all that kind of stuff. So it is, it's its own entity for sure.
For sure. And I think that there is a big gap, even, complex NICU all the way into CV, like
Yeah.
that ventilator understanding, because we really, you know, it's funny you say that, like, I love the CV nurses because they want them off the vent. Like, some
Yeah,
of that is driven by, I don't understand this thing and I want it out of my room.
that's true. Well, even I mean, that's like probably the I think that undercurrent is like also the medical thing where it's like now they're on the vent and everything is sort of okay. So let's not like rock the boat to sort of like, oh, we're gonna like wake them up and extubate them. Like, are you sure it's that, so but the CV nurses, they have to get these peeps moving because mainly because you want the surgeon to come out and be like, why is nobody off the vent and moving, right? That's sort of like we're watching because they you have cases that you have to do, you need beds. And that's why I like the CVICU for that reason. Like it's protocolized to the point where it's just, it is what it is. Like they came out of the case, maybe it's like a simple cabbage, their EF is normal, they're not on a lot of drips, they're not bleeding, like that's it. Wake them up, extubate him, 6 hours, like up to the chair, and you're on your way. So that protocolized approach is something I wish like we could take to every ICU because no one does it quite like the CVICU, honestly.
Yeah, and I try to bring it home to my nurses and say, like a lot of the reason that they would qualify for a surgery like this is because
Right.
they walked in here,
Exactly. Yeah.
and yes, we get the complex, the EFs of 5%,
Sure.
things like
Sure.
that, but like they qualified because they walked in here. And
Right.
so it's not fair to you, to them, for you to, try to keep them on this because you don't want to rock the boat. You want to
Right.
make sure that everything is stable. If they walked in, let's walk out. And I think that is like the perfect framing for fast track, and for how I teach what fast track looks like and how to do it. But I've definitely worked in centers where it's not done, I won't say done wrong, but like when you're pointing to protocols, like I've worked for a place where the protocol was so stringent
Mm-hmm.
that like, and I think I heard you talk about it before, like it can really derail that patient's trajectory when you're
Yeah.
just focused on one thing. And so one thing I wanted to talk about was like those fast track extubation protocols being example of what I worked with before was like, okay, we've hit a certain time. So we've hit the 2.5 hour mark, 3 hour mark.
Right.
Let's pull an ABG. That looks
Mm-hmm.
great. Let's put them on CPAP. 30 minutes
Right.
later, that looks great. Let's yank the tube.
Right.
For
Yeah.
me, that's not enough. And I can tell you that did not go, across the board really well.
And not enough, or what do you mean? Like from the hospital or whatever point of view? Like they wanted more, they wanted longer, they wanted less long.
I think it was more for my patients. Like it didn't go well. The hospital was happy about the number,
Right.
right? But I need more from the nursing side of things. I want work of breathing. I
Oh, I
want,
see. Meaning like for
I
safe
want,
extubation, like parameter type stuff.
right. Because haven't
Right.
you seen a good ABG and the person looks like the crypt keeper?
Oh yeah, yeah. No, I just lectured to a residency group and said, with acute dyspnea, there's no like I don't think hot take acute dyspnea, and there's no role for an ABG or VBG for that matter, just for that reason because you can be look terrible, but the ABG be fine, but they're working really hard for that. So and this is where this like this clinical sort of piece comes in, I think, with RTs, and certainly if you have a CVICU, like have like enough RTs, right? Like the CVICU I work in, like there's a ton of RTs, and we have our protocol. I think STS says like less than 6 hours is the target like sort of
That's the
mark,
mark.
which I got to be honest
Yeah.
with you, I think is like really aggressive. Holy crap! Like you just got your chest cracked in like 6 hours. We're getting the tube out, but that goes to your point. They didn't come with any pulmonary, pathology. So if like you need to control their pain, wake them up. I mean, theoretically, you should be able to breathe, especially if they're hemodynamically intact, not bleeding. There's no other like major metabolic abnormalities. The gases you like, for me, they sort of are what they are. I think I was looking back at the literature that like from the Annals of Thoracic Surgery from like 2018 and before that, I think the guidelines are based on now, and those things were in there like like a pre SBT ABG and intra SBT ABG, which I guess is fine. Honestly, I mean, you guys are sending labs like the Dickens anyway, so you just throw an ABG in there just to see. I guess you could always be hiding some metabolic situation, right? Like every now and then I'll get like, oh, the base deficit's like 5. Like, are you okay with that? I'm like, what's the base deficit again? So I never really know where to put that. I think it's the clinical piece that you have to be most concerned about, like laying the eyes on the patient. So, and that's going to be the nurse, right? The nurse and the RT. So, like for me, if they hit all the marks, I just ask RT or the nurse, like, you think we can extubate, right? Like I just ask the nurse that, like, and they're like, yeah, it's fine. I'm like, all right, pull the tube out. There's certain parameters. So if you sort of qualify, which I guess depends on the center, but I think loosely is like not, crazy hemodynamically unstable, like not bleeding, not in shock, not on a bunch of drips. I guess you can, maybe you can put in like the EF in there somewhere. It'd be more sort of concerned if the EF was lower or if, the patient maybe had heart failure and they got a revascularization therapy, it didn't really get any better, something like that. But if you have like some straightforward fast track kind of guy or gal and their EF is normal and everything, you check all the boxes, you check an ABG, but someone sort of has to like once over them, right? Like after the CPAP trial, either like generally the nurse or RT or ideally both would sort of be like, and it depends on how you, for me personally, my personal approach to extubation is like vitals, neuro, and then like ventilator, just like as broad topics. And if you give me 2 out of 3 that are good, I'll usually pull the tube out. You know what I mean? So if you're like awake alert and the vent looks good, but you're like hypertensive or tachycardic, like I wouldn't necessarily fail them for that because maybe that's just they're in pain or like the tube is down their throat and they're awake and aware. And like just pulling it out would be the best thing for them instead of like, sedating them or something. A lot of times we have, yeah, sorry, go ahead.
So like practically what that looks like, I think is really important because I definitely, the way I've built mine is around exactly what you're saying. But like the CVICU nurses, yes, they want them extubated, but they want perfection. They're chasing perfection. And so I
Man,
have
if
to
there's anything I know, it's that. Trust me. Jeez. I know,
sure.
the perfectionists.
It's more like I'm trying to show that like, okay, I am not worried about postoperative stroke. I am controlling their pain, but like we try really hard for opioid sparing. So I don't know what the pain control looks like for you guys, but we do like IV Tylenol, we do Robaxin.
Yep. We started ketamine for everyone now, like out of the OR, just like ketamine. Straight. Yeah, I know. We love the ketamine. Just like straight out of the OR to try to spare the opioids, which I agree with, certainly. At one of the hospitals I worked at before, they didn't give any opioids. Like, it was very difficult to get an opioid. I think that might be a little too far. I mean, it does hurt. Like, the patient has pain, certainly. I do love when the nurse, sneaks in some Tylenol or like some oxy down the tube before you extubate. Like, oh, we're going to extubate. Let me give you 5 oxy down the OG tube just to sort of like smooth them out for the next few hours. So I think that's a good approach. The best way to do that is to get the tube out and like ask the patient, like, do you have pain? Like, are you in pain?
What
like,
I've also seen is that worked so well at my prior institution was that anesthesia would go in and do blocks.
Yeah, the blocks, right? Exactly.
Before coming out, and those patients, like we would all just be so surprised. We'd be like, "Aren't you in pain?" And they'd be like, "No, not really."
Yeah, you can't feel anything for the next 8 hours. Yeah, no, the blocks work incredibly well.
Neurologically, I think about that. I tell them, we're not chasing fully awake, fully alert. That's not what's going to happen right now. Right. You just want that assurance that they could protect their airway, like that they could respond to you if they needed to. And then I moved to hemodynamics, and again, they're like chasing perfection, and like that's not it. I really harp on them to like, I'm chasing trends. So when you say instability, like so many nurses think, okay, well, I'm not even going to broach the subject because they're on pressors. Right. I'm not even going to talk about it because he's on an inotrope. And for me, it's not that. It's what's the trajectory look like? Is this patient needing escalating support? Then maybe we don't look at fast track. But if they're coming off on, 0.01 of epi just for a little, little bump, then, what does that say? What does that look like for my perfusion? What does that look like, for my CVP and all of that? Like over the next 3 hours, what do you see? Is it escalating the need, or are we stable? I'm not trended towards normal quite yet, and I don't expect that. And I think a lot of nurses are looking for, we want those numbers right in normal, and like I'm not going to achieve that. That's not.
Yeah, no, unfortunately there's no normal button on the patient. You just can't like push the button and everything is normal. Just like you can't make them less sepsis-y by turning down the sepsis-o-meter, right? There's no sepsis meter that I can turn down I say this with driving pressure a lot because we see a lot of, you see a lot of driving pressure content on the socials and sort of like throughout the teaching. And the thing that's frustrating is that there's no we're sort of at the driving pressure's mercy because it's a function of the compliance of the lung. So, if there was like a driving pressure, if it was just easy to make the driving pressure perfect, like then I would unfortunately be out of like a job and like a social media platform, right? Because it's just like there's no button that I can just make it less.
There's no easy button for it.
There's no easy button for driving pressure. I have to like do stuff to make it less, whether that's improve the compliance somehow, recruit lung, or drop the volume, like whatever it is. Like I can't just make it what I want it to be. So like following the trend certainly is probably the most helpful thing. And, expecting that these patients might have some support, whether that, like one of epi and like two of norepi. I mean, is that really, so then what's what is the corollary to that? Like, okay, they're on one of epi, two of norepi, they're like lactic's clear. And, if you check lactic sort of like right after the OR, or if you don't, the lactic's clear, the gas is normal. We shot numbers. It's like CI is 2.5, like it's all good. The EF was normal. CVP is like 10. Like all that in totality is probably fine, right? Like even for our medical patients, this like hemodynamic instability is this really sort of vague term, as you
Vague
brought
term,
up.
yeah.
Yeah, it's a vague term. I know. And that's also, I just talked with Kaylee the other day about sort of like delirium and all this stuff. But, these terms, agitation is a vague term. Instability is a vague term, right? These are vague terms. And for agitation, specifically for SAT and SBT, I mean, if you look at the guidelines, like that's a contraindication to SBT as agitation. So, what does that mean? I mean, I would be agitated also if I had a tube down my throat and I was awake, right? And I wanted it out, one. And two is what I try to tell the residents at least, and maybe you could tell the nurses, like anesthesia does this all the time in the OR, right? They're like not awake completely. They're sort of groggy, but they're breathing and they're, give a thumbs up. They're coughing and they pull the tube out just fine. But for some reason, when they come to the ICU, it's like you need to meet this, amazing level of like perfection or stability for us to feel comfortable like pulling the tube out, and it's very seldomly, it's seldomly that, right? Like it's seldomly the patient like wakes up, they're super duper calm, regardless of what you have on dex, ketamine, fentanyl, like it doesn't matter. Like they're calm and they're just like breathing normal and it's all good. You pull the tube out and they like thank you for that, right? It's just never, it's never pretty, like it's never a pretty sight when they emerge from sedation or anesthesia.
Yeah, no, I guess to sum up that, then I would say, like, I don't agree with the fast track protocols that are like rigid, if this then that, if this then
Right.
that.
Yeah.
And I think the nuance has to be taught to the residents and to docs, but to the nurses as well, because they're the ones that are going to translate that information. And so like I put it in 5 buckets for them is what I do. I say, can we neurologically handle this? Is the,
Right.
Information that you have about where they are neurologically, is that safe?
Yeah.
My hemodynamics, are we not, I'm not even saying like everything has to be within normal limits, but are the trends favorable? Are we
Right.
headed towards normal limits? What does that SVO2 look like? And, how is that trend looking for you? Like you said, the lactate too, is that starting to clear? It's going to be high right after CV surgery, but is that starting to clear? Are we having rhythm switching or anything like that? Okay, then I don't care I don't care if they're on an Impella. I don't care if they're on ECMO. I don't care if they're on that kind of MCS even.
Mm-hmm.
That can code instability, but really the trend is we have them headed towards stable. Let's go ahead and remove this barrier as well. And then of course I say bleeding, because that's the surgical piece. And I think that you touched on it earlier about just looking towards that like metabolic bucket. I call it the other bucket.
Yeah.
Is there anything else underlying that I'm missing that would complicate this extubation piece?
Right. Yeah.
Is there any like acidosis, temperature, pain control that I can make sure I'm making a enhanced oxygen delivery and a better, CO2 removal available metabolically? But then, for me, it comes all the way down. Like you've checked kind of those areas, those buckets, and then you say, can they pass SBT? Does that gas look decent? I'm not saying it has to be perfect. And can they cough? For me, like show me you can cough.
Yeah, no, coughing is probably the neuro stuff. So for me, it's coughing is definitely helpful. But then like if they're coughing on the tube, it's like it's alarming and everyone's like getting all antsy and stuff. So I try to just say like this is normal. They're gonna cough, like it's this is normal stuff. If they can like lift their head up off the bed, and it's like very they're like pretty good strength. As you said earlier, if they came in like walking to the hospital for a surgery, or even if they had some they had some NSTEMI and got in like a balloon pump placed and are going for like sort of an urgent cabbage the next day. I mean, they shouldn't be so weak that they can't like lift their head up off the bed, right? So you should see some like intact strength. Coughing is there's a like some study from I guess the neuro ICUs like maybe 6 months ago or something, where the only thing that sort of correlated with successful extubation was presence of a cough. So oftentimes we'll like the nurses will say they'll like be or residents, and like multiple people will sort of jam things down, varying things down the patient's throat, whether it's the yank hour or something, and say the gag is there as well. I'm like, I don't, the gag is not, doesn't really tell me if you can protect your airway, because the presence of a gag doesn't say you can protect your airway for sure. The absence of said gag also doesn't like say you can protect your airway. So I'm not, I don't ask, like, please never gag anyone. I always tell the resident, like, just don't, if you're worried if they can protect their airway, like, don't gag them, because if they don't have a gag, then that doesn't mean anything. If they do have a gag, it still doesn't mean anything. But if you gag them and they vomit everywhere and aspirate, then you have like a lot of problems. So, try not to gag. And now, like, maybe the biggest reason, it's like uncomfortable to be gagged. Like, no one likes to be like gagged with a yank hour. So let's just try not to torture people if that's possible. That'd be nice.
Torture people, yeah.
Yeah, we try
No,
to
I mean
avoid
more
torturing
like,
people.
yeah, I mean more like, hey, sir, can you give me a cough?
Yeah.
Like a cough on
Yes.
demand. For our populations, that to me is going to be one of the most important. And, getting them off of this support onto whatever intermediary support if they need it, but getting them on that IS and restoring that chest pressure appropriately is what is going to keep them from sitting in this ICU for weeks. So,
yeah. No, we semi recently, so it's not like overly identifiable, sometime within the past 15 years, I had a patient that was post cardiac surgery and was delirious and had all these issues and stuff. And he was strong though. Like he was strong, and he's like moving all fours and able to lift his head up, but was like delirious, like very delirious, because he might have had a stroke and on like all this stuff. And his SBT like wasn't great. I mean, by any stretch of the imagination, he was like tachypnic. He was like uncomfortable. He was coughing. So you're sort of like in this. This wasn't like right after surgery, but like just to the point of I don't think this is out of line, but I think CV nurses, while tremendous, like advancing patients, I think patients that are get stuck on the vent and start, for whatever reason, if they're bleeding or they get pneumonia now and like whatever it is, you start sliding towards this like chronic critical illness like state. Then you really need to be comfortable with this patient's not going to look great, but it's like good enough. So let's pull the tube out. So he was definitely that, which was not great, but like good enough. And so I stayed in the room. I was like, let's just extubate him to high flow and we'll see what happens. And we did that, and he was like, fine. It was like tube came out. He's like delirious, like pleasantly delirious, perseverating on something. I didn't know where he was. He knew that the woman was his wife in the room. But we got the tube out, and like that was that. But I think you could have easily have said, he's delirious. He's not following commands. He's he's breathing 30 times a minute, like all that kind of stuff. And if you looked at the labs, they were like okay, they weren't great. But I mean, I thought, and this also comes with time and experiences. You sort of know the patients where the leaving them intubated is like going to lead to more problems or more, they just need the tube out, right? Like some people just need the damn tube out. It's not going to be perfect, but once you get the tube out, like they get a lot better because like you've removed this like tremendously uncomfortable stimulus.
No.
So is your primary job like nurse education, like an educator, or okay, got it.
Yeah, I'm a unit educator, but it's a really unique position because when I came into this hospital, they were just starting a CV program.
Okay.
And the nurses, the residents, like everybody, they were wildly underprepared, given no resources for it.
Right.
And you are not acquainted with what you do not know. And so when I got here, they were like, well, can you fix it? And so
Always. Never not for that.
Right.
Yeah.
They essentially built me a role, and like the education that I've created for myocardial mastery, like the actual courses that I've built are kind of like grown from, they're the actual flower from the seed that was planted as I created this program. So I teach classes here through my job, but like the goal is to take it to a broader audience and bring it to other institutions now that I have CEs for them. So.
Okay. And then
anyway, so yeah, but I'm still in the hospital, but I don't do a whole lot of like hands-on clinical work anymore.
Okay. So the social media presence, and this is just me wondering, honestly, is like, how did that start for you?
So the dream again is to get my stuff out so that I can go to, administration at some hospital and say, you want this, you want me to come teach for you. You want 100 accesses to these courses for your nurses, and
Right.
we'll create a package. And so I figured the only way to really like get that out there was to go on socials and just put out my teaching style and
Right.
what it kind of looks like and who I am, and sell it that way. And I mean, that is what has propelled me into being able to afford the CEUs and I'll film another
Mm.
set of courses, my MCS in September. So, I mean, it's again grown way farther than I thought it ever could. So,
When did you start?
January.
Like of 26? Oh wow. So now we do our nighttime makeup routine or skincare routine and sort of talk shop hemodynamics, which is pretty cool. And then you've been doing the waveform questions, which I think are awesome because the waveforms are definitely the most underutilized. I mean, like obviously my thing is like the vent waveforms, which is true, but the other waveforms, which is certainly like the Swan and your CVP and your art line and just everything else is like the most underutilized pieces of information, which I guess everything old is new again because we sort of threw the Swan out, 20 years ago for whatever reason. Mainly probably because we don't like. Mainly because I agree that I don't think swans are really particularly helpful in like mixed shock states,
Yeah.
especially if you don't really know what you're doing with it. Not that I'm saying I do, but what I'm saying is that if someone's dying from sepsis, like and the mixed venous is
What are you gonna
70,
get
like
from it?
that doesn't really, it doesn't really help me that much. I do agree, in the MCS world, it's definitely, I mean, you sort of need it, right? Because you need to know like when you need to step things up, or sort of like hard to tell if someone's in like subclinical shock or something, right? They sort of look normal and like perfusing just enough, but like their CI is kind of like on the edge, and like, are we going to do something about that? But the waveform stuff is definitely the most unutilized, certainly, which I love talking to the residents about, like especially the art lines because they love art lines, right? We put art lines to everybody because everyone needs an art line. You already know that because you're CVICU. But you can like really tell what's happening with the patient from like just the art line, right? If they're like really vasodilated, or like if they have aortic stenosis, or maybe just aortic regurg or something now, or like right-sided dysfunction, which is mainly why I hate flow tracks. Hopefully you hate them as well because they're sort of useless because most of our patients have like biventricular dysfunction. It's not like that helpful.
Yeah, I'm
Nice.
excited about some of the like emerging tools like that because I even in my career I
I
have
haven't
seen the
I
Swan
haven't
like
seen them. Which ones are you talking about? You gotta tell me. Like the
so
non-invasive stuff.
yeah, less invasive stuff. There's a
Okay.
finger cuff now that does pulse contour
Yeah.
by Edwards. It's called ClearSight,
Yeah. Yeah.
and I'm utilizing it in my shock program to differentiate early shock. And like
Interesting.
we have a rapid team, so they have the one that we bought, and anytime the rapid gets called, they run up there with it and send me a little screenshot, and I'll figure out, do we need to go to medical ICU, do we need to go sepsis, or does this look like a cardiogenic situation? And those are really the two buckets that we have here, but
Yeah.
help steer where they could go, or does this just need fluid, you know?
That's interesting.
So that one's really cool. We do utilize the flow track, especially in MICU, quite a
Yeah.
bit. Now, of course, like you said, like these illnesses don't happen in a vacuum, but it's still pretty informative. And then, teaching these waveforms, I think can be, I get a lot of pushback on social media saying like, who needs that when you have echo, or who needs that when you have XYZ? And, I say that it's all about early intervention. So if I have this little ClearSight monitor and I can get them help faster, the outcome, we know that it's better. The data shows that they're going to live at a whole
Yeah.
lot greater chance. But
Well,
we
Echo
utilize
is very operator dependent too. Is the other problem, right?
exactly.
Yeah. So we
Well, and I also argue, like, I've seen rural medicine, right, where they've got one echo tech that comes on Tuesdays and Thursdays.
Oh yeah, I know that.
Not everybody has
I
access
am
to
at
these
yeah,
tools.
I'm in like a very large center at this point, and like we can get echoes like
You get spoiled.
whenever, and my fellowship was echo heavy. I'm not an echo like tech by any stretch of the imagination, but I consider myself like not bad. Like I'm probably mediocre to like a little bit better than mediocre as far as echoes go. But to your point, I would echo doesn't still solve the problem, I think. Unless you could do like quantitative echo, meaning if I could sit there and get like a VTI or something, or like an RVSP, or like a PASP,
Right.
that like takes time to do. It's practice, and not everyone can do that. It's a lot. I'm sort of like in the Swan camp now. Like it is easier to just put a Swan and like get the numbers, and then you want to sort of like do dynamic measurements maybe every like whenever. But Swan like gives you that information. And you know, with the waveforms, like you can sort of like start to tell like, wow, is like my, is my AVR, is he like getting, tamponade now? Because like the chest tubes are putting out like 200 an hour for the first 2 hours, and we resuscitate him. Now they're zero, but now
Right.
like, the CVP went from like 12 to 18, and like you have sort of like deeper descent, and you're like, I don't know, this is like looking weird, getting more shocky. Maybe they're, the lactic's climbing. You're not
Truly.
sure.
And I feel
Like
like,
the waveforms are like very powerful. I don't know. I definitely don't agree with that.
I mean, even without this one, like I have MICU nurses ready to be able to say like that diastolic runoff has gotten way lower. Like I may have still a map goal achieved. That's my favorite line.
Yeah.
Map goal achieved. But, I can see that my SVR is falling out.
Yeah.
I've
Yeah. Yeah.
had them be able to call it that early is so valuable. And then you have the residents learning that and seeing that. And I just think that that translates, downstream into much, much better outcomes. I've had nurses, they pop in an art line on somebody that's here for something completely different. And we find this looks like they've got aortic regurg. Like, has anybody checked them out for this?
Yeah.
Like, maybe that's what this bronchitis is about.
Yeah. No,
This
the
backup
bronchitis
that
is
it's
definitely,
caused.
yeah, of course. Oh God, don't get me started on bronchitis. That's good. So is that, that's your, like the teaching and stuff, and like the nurses identifying that, the residents, for example, that's, I mean, not just, you can sort of pat yourself on the back. I mean, that's your sort of like moving in that direction towards like getting, like sort of like, like a rising tide lifts all ships. Like everyone sort of like
Yes.
starting to understand like what these waveforms mean, not just, that like the map is 65, but, the systolic is 130, the diastolic is 40. And, that dichrotic notch is like really, really low, and sort of like like this sort of like distributive increasing SVR, maybe aortic regurg, like identifying that stuff. That's sort of the like the philosophy behind like your approach, I guess, is a question.
That's absolutely it. And I've just seen, and you probably have too, in critical care, specifically in CV for sure, the like knowledge guarding that goes on. And like, if
Yeah.
I know it, then I'm the most special, and then you're not special.
Yeah. No, for sure.
And that just does not translate for me to good outcomes. I want all eyes to be able to pick it out
Yeah.
and at least question it. I mean, what
Yeah.
if it means nothing, then it means nothing, but at least we all, investigated it. At least we all
Yeah.
thought about it, and maybe the next
And
time it means something, you know.
yeah, you'll get it. And
And that
it like the device you put in, whether that's an art line or a swan or whatever, like, you want to use it to its max capacity, right? You just don't want to put an art line in just to get like Q2-hour ABGs or something. You want to,
yeah.
like, that's giving you a lot of like hemodynamic information. I especially like them for sepsis, to be honest with you. Like, if I'm not sure, if I'm like, is this, whatever, because when you pop in the art line, you see a diastolic of 25, you're like, this is, and because A, this is like not good. That's all, like automatically we're like not in a good spot. But B, it sort of like cinches the diagnosis for you more, I think, if there's some question about it. So I think that's great.
I
I
like
mean,
that line that you sorry.
What?
I like that
No,
line
go.
that you just said, using those things to their max capacity, not just putting them in.
Yeah.
And like,
Well, it's
yeah,
like,
I'm gonna have to steal that. That's
oh, please steal it. Yeah, yeah. I mean, it's like the vent too, right? Like there's all this, much like the swan, and I'm not a swan expert by any stretch. Like I'm sort of like very pedestrian with it. But, swan vent, I mean, you can tell a lot what's happening, and like real time physiology, like in front of your face, that without having to like send labs or, get another echo and that kind of stuff. Like this is real time physiology happening. And so I think these monitors, they give you all this information that we don't use to its max capacity because we don't understand them. Swans, I think probably because we haven't used them, I think in totality as like, certainly as a critical care. I mean, CVICU and CICU, obviously, but from like a medical side, we've sort of like threw those out a while ago, but I think they're starting to make a resurgence because people are having, they have septic shock, sure, but they're 55, they're septic, they have some, I don't know, whatever, but like their CI, we sort of, their lactic's climbing, and like, what is it? You put a swan in, their their cardiac output's like 3. Like what, there's a real decision to be made there, right? Like again, there were not many patient identifiers. So sometime in the last 100 years, I had a patient that had like a very low, like, was in septic shock for sure because she had bacteremia, but, had, like, I POCUSed her, so back to the echo thing, and her EF is like 10%. It was like low, right? And we can probably talk about. I think EF is the most overblown sort of like value that we get. Like it doesn't really tell us a number. It's like EF to me is an outpatient thing. EF is 50%. It's an outpatient cardiac thing,
Is an
right?
outpatient thing.
I'm interested in the stroke volume. So what is the stroke
I'm interested in
volume?
the stroke volume. I'm
We're interested in the
interested
stroke
in
volume.
the
We're
the
interested in cardiac
myocardial
output
capacity.
yeah, we're interested in the cardiac index. That's what we're interested in.
Yeah.
So for me, I generally can get a VTI of the LVOT and then sort of like plug and chug and get like some non-invasive numbers. The cardiologists generally don't care what I say about that because they're just like put a swan in, which is fine, honestly. But what I'm trying to say is that we identified her as like, wow, she has sepsis, but she's also like in cardiogenic shock, right? And we're treating the
Septic
sepsis, but
cardiomyopathy is a
yeah,
thing. Yeah.
exactly. But she's only 50 years old or something or whatever, was young, certainly. Can we do, not that putting everyone with sepsis on ECMO is like a great idea, but, are there certain things, should you roll the dice with some people and like maybe they'll get better? So we went down that path and ultimately didn't go that way. But still, in days past, I think we probably would have said, oh, wow, she's septic. Her lactate's still climbing. We should give her more fluid, right? And then you just would have killed
Right.
her
I
with
was going to
fluid.
say it can
Yeah.
change the treatment trajectory, and even if we may have fallen too far, like maybe we add an Impella, maybe we switch some of our drip strategy, like some of our
Yeah.
medication strategy.
Yeah. Or add an
I
ionotrope.
mean, right.
Yeah.
And what I see most often, like the other kind of piece of my job is still like I've built and I run our cardiogenic shock program. I
Okay.
see a ton of like missed early
Yeah.
identification.
Yeah.
So seeing the early stages of shock and automatically hitting sepsis. And then they
Yeah.
get all the way to the medical center and see that like, oh, they've really, really poorly mismanaged cardiogenic shock.
Yeah. Now is that
And
like in
so,
the community and then they come to you, or is that like in the?
right.
Okay, got it. Yeah.
Yeah.
So
And,
it's a not, you don't have to be specific, but it's like you're at a large hospital, like a larger.
a
I'm assuming
tertiary
it's large.
facility. Yeah.
Tertiary facility. Okay, so we're getting calls from the community for like shock stuff, and like they transfer them to you, and then sort of like figure it out from there.
Yeah. Yeah.
Okay, nice.
Like I carry the shock phone and they call and say this patient looks on death's door here.
I know,
So
right?
we yeah,
Thanks,
we
everyone.
we try to take them and figure it out, but I think I think providers like you who are willing to at least dabble in the POCUS and take a look can give us the at least the idea, do we need a swan? Do
Yeah,
we want to watch those dynamic changes? Because the other big thing that I think that we underutilize, and I get a lot of again pushback on social media about we don't need a swan because we have echo, and it's like, okay, but are you sitting there the whole time? Are
yeah.
you
It's
watching
not
with every
possible.
intervention that you've done?
Yeah,
Like
it's not possible. No,
that's
I agree.
not
I 100% agree. I'm after CVICU time. I'm like, you know what? It's just it's easier in a lot of ways. The times where I get sort of like I get I get sort of my britches in a twist is if I do an echo and I'm like, this is the LVOT is like, or the VTI is some, it's high, it's like whatever 30 or something, and they're like, no, we need to put a swan in because they might be in cardiogenic shock. I'm like, I don't think it is, but that's not everyone can do that, and it's like and I'm don't get me wrong, I'm like a POCUS guy, but you're right. It's time consuming, and when you have, it's time consuming, and it's not practical in some ways,
and it's a real
at all
skill.
times. Yeah, because you
Yeah.
have 15 patients, like you can't POCUS everyone every
Two
4 hours
hours.
or something. Yeah, it's just like not going to work. That's why swans are, I think, they certainly have their place for sure. And I think, the more we use them, the more we'll be comfortable like interpreting the data that we get from it. You know what I mean?
Yeah, no, definitely. I think there's a language you learn to speak, right?
Yeah.
And I'm just now getting to the point where I've got my nurses kind of marrying what they finally speak in way, like they speak Swan finally, not just the numbers, but the waveforms, and now adding to it, like I'm sending them to you, to see those ventilator waveforms. And like, I mean, for us, for sure, like this is a heart failure unit, VAD, transplant, things like that. So we are
Yeah.
all about the people's ventricle.
Right.
And
Of course.
so really heavy on teaching how the vent interacts with my RV and, how we can partner with RT to manage that in a really, robust but safe way, which, I mean, as we move into LVAD and what I've experienced with LVAD in the past is like, we fix the LV, so our focus has to be
Yeah.
RV,
Right.
and that means ventilator go away, completely go away.
Yeah. Yeah.
And so
No, I mean, it makes things
you're,
definitely much worse. I mean, it makes a lot of, it makes a lot of things worse. Definitely make the RV worse. And I think, the vent stuff. So I am in like a very small part of a course that was sort of founded in this area from that started like sort of at my hospital that I was training at, and then now it's sort of based out of the NIH / University of Maryland that we teach fellows and attendings like throughout the country, sort of the vent sort of approach. And what we do is exactly what you said, is like you need to speak the language. It's a whole different language that you need to speak. The problem with mechanical ventilation, I think, definitely in America, because our South American friends like Argentina, Brazil, like and like Australia, like they know their vent stuff like way better than we do. I've like interacted with them a bunch, but like for doctor side of stuff, there's no, when I graduate fellowship, I don't get like I become an expert, right? But I don't like take a board to say that I'm an expert in ventilation. So you have this like very wide swath of people that have like differing levels of comfort with the vent. From like, oh, the RT will take care of it, and RT same way. Like there's a very large sort of dimmer of like, some people are super comfortable and know, some people are very uncomfortable and like don't know, and there's no secondary training for anyone, RTs, nurses, physicians. You learn what you learn in school, and then like that's it. You just sort of like, it's just sort of it's just like RT's problem, but depending on your RT,
and
you might not sort of like, you know what I mean? Yeah. So if you have a
yeah, you have to
fragile
stand in
patient,
that and like, sorry,
no, if you have a
standing in
fragile
that like,
patient with an like an LVAD and like teetering on death from their RV dysfunction, and you're crushing them with auto peep, like that's probably not a great idea. But if no one can like identify that, then that's a problem. So that's sort of like where this like vent stuff is coming. Unfortunately, is like super duper niche, but it's like a real need for every
it's so
space.
needed.
Yeah, for every
Like we
space
were
it's
saying, where
needed.
I stand in that knowledge gap space, trying to bridge that for like the hemodynamics nursing piece, like that
Yeah,
is so needed in the ventilator space in the same way, like where
yeah,
you're standing. But yeah, I want to hear more about, because I have heard you talk a lot about the auto peep, and I want to hear more about like how we see that these LVAD patients, it's so complex because they're not virgin chests. So you do see a fair bit of like intensivists wanting to use PEEP to tamponade.
yeah.
And then, like that's that's increasing, potentially increasing my RV afterload and definitely decreasing my RV preload.
Hmm.
That's my feed for the pump that we just put in. And so
Yeah,
you're up against that, as well as like these patients are so deconditioned. Like these patients are so sick going into it. I mean,
right.
even if we get our good Intermax 4 or 3 or something like that, where they are walking around, like their body has been in heart failure so
Yeah,
significant that they need a pump. So all of our body systems were kind of struggling to climb out of the hole. In my experience too, you see a lot of like diaphragm dysfunction and
yeah,
lack of muscular use because of all of this wasting that they've experienced with this disease. And so like that, on top of these patients are this hurts, this is often not a virgin chest, and it hurts even more, and they remember what it felt like, and so that's compounding it. So that vent dysynchrony, the auto peep adding to it really, really complicates that picture. I don't know if you've ever seen or recovered LVADs, but I think it
yeah,
really gets to be where everybody's kind of in this tug of war to protect the RV, but also ventilate the patient.
yeah. I mean, so specifically with like this RV protection, let's say, there's that nice figure from that's been around forever where your RV afterload is the highest at the two extremes, which is at your residual volume. So if you sort of like blew all of your air out in the lungs and sort of like they got smaller, but that's also ARDS and pulmonary edema to some degree brings you sort of closer to your residual volume as well, because you get atelectatic regions, right? Like sort of heterogeneous regions that aren't aerated. So, that increases RV afterload. And then as you get to your total lung capacity, that also increases RV afterload. So sort of like in that U shape in the middle that we call FRC, functional residual capacity, is where you have the sort of best balancing of the forces, and the RV afterload is the least. The problem with this is that there's no way to tell where the FRC is, sort of like at the bedside, right? It's kind of hard to tell in the pulmonary function lab where it's at. So do like nitrogen washout, get FRC, whatever. But certainly if someone's like dying from ARDS, I can't like look at the x-ray and say they're at their FRC. It's just like not possible, right? Now, so this becomes a little clinical to some degree. Number one. Number two is auto PEEP. So, you set some number of PEEP, and then if the patient doesn't have enough time to exhale, then they have like leftover gas in their chest that exerts a pressure and sort of above the set PEEP, and that difference becomes the auto PEEP. Some people just increase the set PEEP. Therefore, when you do the math, you have no auto PEEP. So that's not like, but let's keep that over there for a second, right? For 1 second, because the way that we get auto PEEP is we don't give patients enough time to exhale the gas out. And that's based on this thing that you might have heard me talk about. It's called a time constant, which is a term that also has to do with sort of arterial hemodynamics, because what it has to do with is like something flowing through a tube based on a pressure differential. So in the lungs, it's air, and in like the vessels, it's blood. So sort of like how long it takes to sort of decay back to this sort of where you've ejected all the blood or gotten out all the air. So it's based on the resistance of the tube and then the compliance of the tube. And in the lungs, like the airways, right? So things that increase your compliance, like COPD or emphysema, you need longer time to get the air out. Things that affect the resistance, like asthma, you need longer time to get the air out. You probably know, because you've been a nurse for a long time, even though you're only 30.
7 years.
Yeah.
Obviously.
That people who have ARDS, right? Like we can ventilate them often like 32 times a minute or something, right? Because their compliance is so low that their lungs are just like rubber bands. They just like snap back. Whereas COPD is exactly the opposite. Like they're like plastic floppy bags. You need a lot of time for them to get the air out. So this sort of like long soliloquy is that when you talk about FRC auto PEEP, it's not really like the number, like the auto PEEP, because you can, if there's, if your set PEEP is 5 and you take a measurement and your total PEEP is 10, then 10 minus 5 is 5. You have 5 of auto PEEP. If the intensivist comes by and says, well, just make the PEEP 10, if you do that math again, then you have no auto PEEP, right? But you didn't really get what you're doing is you're not ventilating the patient according to their mechanics. So the time constant is based on the mechanics, meaning we get an actual number for the resistance and the compliance. If you multiply them, you're left with seconds. You need 3 time constants to get all the air out. So if one time constant is 1 second, you need 3 seconds to get all the air out. If your inspiratory time in inspiration, is 1 second, that means your total breath time, inspiration, expiration, is 4 seconds, okay? Meaning, if you breathe any more than 60 divided by 4, which is 15, you're going to get auto PEEP, okay?
See, and that's a brilliant thing. Like, and that, I mean, the way you describe it, it does sound so simple, like to see that.
It is simple. It's very simple. The problem is that we don't teach it that way.
We don't teach it that way.
We don't teach it that way. Because if I said to you, what's the I to E in that situation? It's 1 to 3, right? Yeah. But if I mess around with the numbers, I can make the I. So you probably see Melody Bishop. She's my RT, not my RT. She's RT that teaches the ventilator, sort of similar to me, but we have a lot of similar, almost like 100% sort of agreement on a lot of stuff. But the I to E is sort of a useless number because it's a ratio. So you can make, if the I time is 10 seconds, but your E time is like however long, your I to E is normal, but it doesn't ensure like normal mechanics. So, the next step is like if you're ventilating some LVAD dude and you're worried about the RV and like auto PEEP, because that's certainly, you're not ventilating them along their sort of like mechanics. So whenever you don't ventilate them along their mechanics, they're always at risk for sort of like barotrauma, but also ineffective gas exchange, right? So the RV doesn't like hypoxia. It doesn't like acidosis. It doesn't like increased pressure. So if you're ventilating the patient along according to their mechanics, so no longer auto PEEP or, the set PEEP is 5, but the total PEEP is 8. So we made, there was auto PEEP at 3, but we just made the PEEP 8. Therefore, we sort of washed it away. That's not ventilating them according to their mechanics. If you ventilate them to their mechanics, you will probably be at FRC. You know what I'm saying? Like, so FRC isn't really like a number. It's not really like a number that you shoot for. It's sort of like, this idea of ventilating people according to their mechanics in that moment. Mechanics can change, right? You treat the asthma, the resistance gets better. You treat the COPD, whatever, maybe the compliance gets better. You treat the ARDS, the compliance gets better, right? So, and this is a number. So what kind of vents do you have, by the way? Do you have servos or PBs?
Hamilton.
Hamiltons. So Hamilton actually, they give you a lot of info on the screen, much like your waveforms. We generally disregard it. The way you automatically know that that person has no idea what they're doing is if they put the flow volume loop on or something, or the pressure volume loop. If they put the loops on, that means that you're in big trouble because I have no idea what's happening. Because if you need the loops to tell you what's happening, then it's like all bets are off. So just that's a little caveat. If you need the loops to figure out what's happening, then it's like you're in not a good spot. Because most people don't really understand the loops is really my point, much like the waveforms, much like the vent waveform, but also much like the hemodynamic waveforms. But, so if you're in like APV or PRVC, which we all love, people sort of like start to put the waveforms on if patient's not doing well. And I walk by and I'm like, why do you have the waveform on? They're like, oh, because I wanted to look. I'm like, you don't know what's happening. And that's fine. Like, I'll teach you. But this is not, when you would use the waveform. You know what I'm saying?
Yeah.
So this was a long-winded answer to your question, which was like, what do you do with the PEEP in that situation? What you should do is ventilate the patient according to their mechanics at that time. The best way to do that is with the time constant.
Yeah. And I think I really want to teach my nurses to advocate in that way. I mean, just like you said, there are some RTs that really are sharp on it, get it. We don't have to say anything. But
Absolutely.
When we have these very tenuous patients with, we're protecting this RV, I'm looking directly for it, and having them trained to see it is going to be important. But I also think like the hemodynamics of like the consequences of seeing this auto PEEP. How hard do I need to get on top of somebody to fix this? Am I truly seeing my CVP lower? And I always tell people, like, make it make sense,
Yeah.
I don't know if you've worked like CV surgery. Nobody wants to admit they're tamponading. Okay. You'll call and call and call.
Yeah. No,
They can't be tamponading.
Have you given factor 7 yet? No. Okay. Factor 7 for sure. Right. Yeah, of course. No, it's never, listen, Karen, I already know it's not surgical bleeding. You don't even have to ask that question. The TEG is normal. Like, what else do you want? And they're still bleeding. Like, there's not really much else I can do here. And then, that, and don't get me wrong, I'm not like some CV surgeon whisperer, but you have to sort of, I tell whoever I'm training, you have to like put them in this position where it's like, you can't say no anymore. Right.
Right.
Like if you take care of all the things, you can't say no anymore.
For sure. Like, make it make sense. So if you're watching that CVP rise up towards that PA diastolic, like, did you give a whole bunch of fluid? Why would that be happening? And so if we're getting this auto PEEP that really is affecting that RV preload, like, are we decreasing that venous return? Are we increasing RV afterload? Like, really hone in on those RV dynamics and see, can we get them to, a safe spot on the ventilator, because it may not be an option to yank this tube right now. We really need to do the best we can to like walk together instead of, I have had those instances, you probably have too, where like you have an RT that really knows their stuff. They're way far ahead of what that bedside nurse can see and understand, and then vice versa, Yeah. And so kind of my whole point is like making sure that like everybody, man, the way you explain it is perfect. I'm gonna have to steal it too. Bring it to my nurses for sure. I hope they're gonna watch this. They're excited. But yeah, to make sure we're all kind of empowered to see the same things so that we can speak the same language, and watching for that auto PEEP, because I think that's one of those kind of sneaky things, especially as we're going to rest them on the vent. Like, what does rest really look like for a patient like this?
That's a great question. I mean, what does that mean? We can do one better. I mean, do you ever want someone to rest on the vent is a probably question, right? Like, and this has to do with like the language, I think. And I'm not perfect, like I say this too, but only because I know that's like sort of the lingo that we use. But you mentioned diaphragmatic dysfunction. You can get diaphragm dysfunction very quickly with the ventilator, either over assistance or under assistance. Within a day, you start to see sort of like changes in the diaphragm thickness or inflammation, or it thins out. And then sometimes our patients, especially in the CVICU, like they're super duper sick, right? And some people they can't like interact with the ventilator, right? Because once they start breathing, then like the balloon pump alarm goes off, like they start sucking down the circuit. You just can't they're not ready to sort of like interact with the outside world. And that's one set of sort of patient, right? But there's this other set of patient that, we want them doing at least a little bit of work on the ventilator, right? Like a little bit of work, because we want them not to lose their diaphragmatic function, right? So, I mean, how much work is that? And I don't have an answer for you. I can tell you that I at least want them to trigger the vent, right?
Mm-hmm.
So all the time I walk around the unit and I'm looking, and like, if they're not triggering the vent, I tell our team, like, just drop the rate. They're like, but what, the gas is 7. I'm like, I don't care what the gas is, drop the rate. Because remember, we're not, and this again has to do with sort of like how we teach mechanical ventilation, sort of definitely in America. We're like very PCO2 sort of heavy, right? Or end tidal. Like the end tidal is 40. Like I'm like, I never care about the PCO2 ever. The only time we care about the PCO2, and that's only in the context of the acidosis, is really in like brain injury and RV dysfunction, right? So yeah, if you have a sick if you have sick RV, then you can't sort of tolerate acidemia. But it's not so much like the PCO2 itself. But you should never sacrifice safe pressures to achieve some PCO2 number. So the PCO2 is 50, so I went up on the rate and now I have a bunch of auto PEEP. Like that, you shouldn't do that, right? You should, tolerate some permissive hypercapnia, which is like this sort of this approach that, says that we should avoid ventilator-induced lung injury by trying to chase this PCO2 number and just sort of like accept whatever the PCO2 is, but ensure that the pH is acceptable. That's a huge moving target. Some people can tolerate a pH of 7.2 and you won't even know it. Some people get to 7.25 and are like falling apart. So, you need to sort of like do that dance, but there's no sort of number that you need, that a PCO2 certainly that you need. So, it's all about like the vent sort of approach, and the approach that I use is the approach that we teach to the fellows and the attendings and all that stuff. But it's a whole separate language, it's a whole separate way of thinking. The other, I think, issue is, and you could probably, I think you'll agree, is, in America, certainly RT kind of like owns the ventilator, right? Like in a lot of ways, you know what I mean? So, and I'm going to say, I would say 40% of the intensivists have like poor working knowledge of the vent beyond sort of like simple dimple stuff. The other 40% sort of like in the middle, and maybe like 10% of intensivists in the country are like high functioning with the ventilator. So if you're an RT, next some new attending, and I'm like, make the rate, 15 because of the auto PEEP, they're going to be like, yeah, right, dude. You don't like, that's like, what are you talking about? Right. But so when I do my real job, even though I'm whatever I do here, I was just, like recently I was sort of not at work, somewhere else. I was sort of mansplained the vent, and I said, I was like, you know what? I think I know this thing like a little bit better. You should probably, this was,
this has been,
we're going to have
awesome.
to talk again. This was good for sure to discuss like, the two worlds and like the two approaches. And I think now that sort of got like a better idea, I think this is sort of like same approach but different topics, right? Meaning like this thing that's like underutilized with the ventilator waveforms, or the hemodynamic waveforms, and like how do you sort of like train everyone up to recognize at least simple patterns on the machines that you use? Because then that sort of, that can't do anything but like help the patients and like identify like sick people or that kind of thing. So I didn't think of it like that until just now. But that's awesome.
No,
any parting thoughts?
I had a lot of fun. I really enjoyed this. I love talking the interface between what the vent can give us, but what it costs, in way of hemodynamics and yeah.
No, definitely costs something. That's for sure.
Nursing, for instance, takes it for granted. It's there, it works, and come out whatever. But how we can coexist and coexist really well, I think, is a space we can explore for sure. I'd love to do it again.
Yeah, no, absolutely. We can chat anytime for sure. Well, you keep putting out great stuff, and I'm like, oh god, Karen has a waveform up now.
I listened to all your stuff.
If I don't get it, I'm gonna feel stupid. So we sort of go through it, and then I get sort of like, this is like, I am sort of hyper focused. So that's not a great thing to put yourself up against, because like I said, a lot of our intensivist friends are not, and that's a problem vent education specifically, is that we don't have enough of it, and it's definitely not structured like in any stretch of the imagination. So that's why depending on where you work and who you work with, like everyone has differing, approaches. And not that I'm saying that my approach is particularly correct, but the way that we teach
Right.
it
And
is
that's
we're
how I
sort of
feel. I'm
like
not saying,
physiology based.
gosh, people
You
on
know what I
social
mean?
media think
So-
that that's exactly what you're saying. Like, I'm right. But yeah, no,
Oh, I know.
I feel like
Yeah.
there's so much on like how your education starts and who you surround yourself with. I think your stuff is hella great. I love it, hyper focused or not. I think that, I mean, like what was it? The ventilator book is what I love by Dr. Owens. That's what I hand like all my residents as just like a baseline. And I think it does take exposing yourself to different levels and differing, pieces of understanding, because the way I explain it or the way you explain it might not be exactly how somebody absorbs it even. So
Yeah. Especially this stuff. It's like, I mean, vent waveforms, but also hemodynamic stuff is, you have to hear it like over and over again and see examples and like, but there is no, your nurses and like whoever works there is lucky they have you. They can like bounce stuff off of you, and hopefully they, take pics of like screens and say, this is what was happening.
Yeah.
Like, what do you think? Like, what do you see? Right? Because that's something that we can't like replace with AI. No matter how much we want to, is like how much, what do you see when you see that, and get like the clinical history, like what's happening, like what comes to your mind, what are you worried about,
content honestly
like
comes
that kind of
from,
stuff,
is, like,
so
I see
it's
it.
good that
so
it's great that you're,
let's do it. Let's
a
send a
resource
picture
for
and
them,
let's
so.
do it. So yeah, no, we'll have to.
Yeah, no, that's awesome.
Yeah, please.
I'm gonna send you waveforms now.
Please.
I'll send you Swan waveforms
But
and
yeah,
be like, Karen, what do you
let's
think?
definitely do it again. I'm down.
Yeah, no, for sure.